Welcome, everyone. For those of you who don't know me, I'm McDermott. I am a psychiatric mental health nurse practitioner, and I specialize in dementia care. I've been doing this for about 20 years. I've been a nurse practitioner for about 32. And I am also a co-owner here at Town Square. And I see lots of familiar faces of folks that have either been here before or are members here at Town Square who I have the honor, privilege of taking care of. So my goal with this one always is to kind of do a little bit of an overview first, just about the disease process itself, and then kind of talk with you all, it's sort of singing to the choir a little bit when you do caregiver support and the issues that most of you face. Many of you are going to see lots of nodding heads throughout this as you're like, yep, that's exactly what's going on. So I'll try not to simplify it too much, but also not to go into too much depth. I usually speak for about 40 minutes and then leave about 20 minutes at the end for questions. If you have something pressing that you want to ask, feel free to interrupt me, but otherwise I will take questions at the end. Then I have to get this to work.
More technical difficulties.
All right, so our objectives today. The attendees will be able to talk about the types of dementia. We'll talk about caregiver demographics, which I always think is really interesting. Some caregiver stress, and then strategies to prevent caregiver burnout. So we're going to talk about dementias, and if any of you have heard me speak before, you know this is one of my favorite topics because it always fascinates me as to how little we know about dementia. And it always saddens me to think about how far behind we are in terms of taking care of patients with dementia. I was talking to a family member yesterday. We were talking about cancer and how, 50 years ago, if you got diagnosed with cancer, it was a death sentence, right? But now there's hope for cancers. Dementia has really only been respected for the last 20 or 30 years. And so we're way far behind. You get the diagnosis now, it's a terminal disease. We have no options for treatment. There are new treatments, there are new ways of detecting Alzheimer's and dementia that are coming out. And I think in the next 20, 30, 40 years, we're going to be sort of where we are now in terms of, the cancer diagnosis. So again, dementia is that big broad term, right? So dementia basically means that you do not have the cognitive ability to live independently. So what does that mean? Can you pay your bills? Can you feed yourself? And I don't just mean take the food out of the refrigerator and heat it up. Can you figure out how to get to the grocery store, buy the appropriate groceries, bring them home, cook them, and feed yourself? Can you do that? And we don't really think about how much cognitive ability it really takes us to do all of these things, right? And then there's onset and stage. So onset means when did your symptoms begin? Early onset is before the age of 65. Early onset and early stage are not the same thing. Early stage means where are you in the trajectory of your cognitive decline, right? So early onset would be before the age of 65, late onset would be after the age of 65. And it's very hard because people will come in and say, oh, well, she was diagnosed last year. But she was diagnosed last year and she already was completely disoriented, couldn't care for herself. So diagnosed and actually onset are two different things. I always typically will say to my family member that, okay, well, when did you start noticing symptoms, right? Because if you started noticing symptoms 3 years ago, she probably had the disease 2 to 3 years before that. Because they're able to compensate early stages, stage 2, stage 3, they write notes and they shy away from challenging situations and they have all these ways to compensate for the fact that they're early stage, right? And so a lot of times they can hide that for a long time, right? So then we talk about stages, onset, and dementia. Okay, so now we're going to talk about the different types of dementia. And I tell people again, it's very similar to cancer. If I said to you, oh, I was just diagnosed with cancer, your first question would be, what kind, right? Where? Because if I said, oh, I have a basal cell, that's very different than if I said I got pancreatic cancer, right? It's a whole different ballgame, right? The other thing is that I would never go to my doctor and say, hey, I got skin cancer, so I'll never get another cancer again, right? Possibly you can get two. Same is true with dementia, right? So Alzheimer's disease, which was named after Dr. Owens Alzheimer, is by far the most common and frequently seen type of dementia. Now, having said that, just like with the cancer, many people have vascular issues with high blood pressure, high cholesterol, uncontrolled, vascular disease, and that can lead to vascular dementia. So vascular dementia is the second most common. And then when you mix those two together and you get a mixed dementia, I really think the third most common is a mixed dementia, and it's an Alzheimer's and a vascular. People can have a vascular dementia if they have stroke. Very oftentimes we'll see somebody who's having some mild decline, they have some mild ischemic changes, meaning death in the brain itself, and then they have even if it's a small stroke where they can still walk and talk afterwards, but yet we see this rapid decline in their cognition. Typically, once you've had a stroke, it is very likely that you will have another stroke. And so a lot of times with these people, we see more of a stepwise approach where they'll sort of go along, and then boom, they kind of see this drop, and we know that something has happened in their brain. And then they'll go along for a while and they'll have a drop. So we see the stepwise approach, which is Alzheimer's. It's more that very slow and steady kind of decline. And you don't see it as much as the caregivers, but your kids come home, they haven't been home for 6 months, and like, wow, dad's really declined, right? Because they really see that difference that you're not seeing every day. Lewy body dementia is a dementia most commonly seen with Parkinson's disease, and it's called Lewy body disease. It's named after the doctor who came up with these, what we see on imaging, which are these little Lewy bodies in the brain. Lewy body dementia is a very specific dementia. It is characterized by hallucinations and delusions, agitated behavior, and very aggressive behavior. It often happens to younger people, and it is extremely difficult to treat. It's one of the number one reasons why we see people place their loved ones because they can't get the behaviors under control of the Lewy body. And then frontal temporal lobe dementia is more of our younger folks. These are the people who have the primary progressive aphasia. Everybody talks about Bruce Willis. This is what he has, the frontal temporal lobe dementia. Primary progressive aphasia is the inability to get your words out. You know what they're there, but you can't get them out, right? We also see a lot of behavioral changes with frontal temporal lobe dementia. The frontal lobe is our impulse control. So this is where we have a lot of inappropriate sexual behaviors, right? Boobs. Men love them, right? They know not to touch them because it's socially unacceptable to walk up to a woman and grab her breasts. When they have frontal temporal lobe dementia and they have no impulse control and they just think, wow, that looks nice, I want to touch it. And that becomes a problem when these people are living in the community. They make inappropriate statements about people in restaurants, in stores. It becomes very difficult for family members to take these folks out. And it's people don't understand it, and there's a lot of stigma associated to it. It's a really tough one. And then there's other causes of dementia that, the Parkinson's disease we talked about, Creutzfeldt-Jakob disease, and mixed dementias. There's alcohol-induced dementia. There's CTE, which is chronic traumatic encephalopathy. You don't have to be a football player. You could be a downhill skier who had a bunch of accidents. You could be a soccer player who used your head too many times. You could be an abused wife who got beat up on a regular basis and have CTE. So, it's become more prominent and we're more aware of it. But we used to think, kids that get banged in the head was no big deal, right? Now we know that concussions can really cause significant long-term damage to the brain. All right. All right, let's talk about caregiver demographics. About 1 in 3 caregivers, 30%, is age 65 and older. 1 in 3. Approximately 2/3 of caregivers are women. More specifically, over 1/3 of dementia caregivers are daughters. Most caregivers, 66%, live with a person with dementia in the community. There's a lot of I think misinformation that people with dementia live in assisted living facilities or skilled nursing facilities. 66% of them are out in the community, and honestly, I think that number's low. I think it's closer to 80% are out in the community. I think there's a lot of people living in the community who haven't been diagnosed correctly. And I know that because a lot of times by the time they get to me, they've just gotten the diagnosis and it's clear that they've had the disease for 5 or 7 or 8 years. So that means they've been living in the community without anybody knowing that they're impaired. Does that make sense? All right, caregivers. What happens to caregivers? They suffer from high levels of stress and frustration. How many of you would shake your head with that one? Why? Why do caregivers have high levels of stress and frustration? Well, I think a lot of it goes to, number one, again, people don't understand the disease. Number two, typically, if you're the wife or the husband of the person with dementia, you're looking at your husband who used to be, or your wife who used to be your partner, your soulmate, the person you go to and get advice from. I spoke to a woman this morning who's struggling terribly with finances because she never did them. Her husband did them her whole life. And I spoke to the daughter and she's like, yeah, mom's really overwhelmed. She doesn't know how to do any of this. And here's her husband. Here's his body at least. Maybe a third of his mind is left. And she's lost that partner. So I think that's really where a lot of the stress and frustration comes in. And we're going to talk about that a little bit farther into it. Frustration in terms of the healthcare system. I go to the neurologist. The term I heard at the last convention I was at was diagnose and adios, right? So you get the diagnosis, adios, see you in 6 months, right? And I thought that's a great phrase, right? Because so many of my families come to me and say, we went to the neurologist, we got no help. And I remind them that neurologists' job is to diagnose. That is their job. Their job is to make sure that there isn't some other organic reason why your loved one is having cognitive impairment, right? We need to make sure that it's not a normal pressure hydrocephalus or a brain tumor or something else that could be causing it. Once they're done with the diagnosis, there really is no treatment for the disease, right? So there's really not much else for them to do. That's where the psychiatric providers come in because we treat the symptoms and the side effects, which are typically anxiety, depression, agitation, irritability. We're the ones who treat those. And so a lot of times people come in and they're like, these are making me crazy and I don't know what to do. And I went to the neurologist, to the primary care, and they say, I get the shoulder roll. Not much we can do. And that's where the psychiatric providers can really help in terms of making sure that they're on the right medications to bring that temperature down. So that's where a lot of the stress and frustration is diagnosed. Because of that, a lot of caregivers have a really high level of depression. They're entering the winter, their autumn and winter of their own lives, right? Nobody plans to grow old with their spouse and wind up not being able to travel and not being able to enjoy themselves and not being able to go see the grandchildren and do all of the things they wanted to do because now they have a child, literally, that they're taking care of, right? And so that level of depression is really that overall, that constant stress and frustration, raises those cortisol levels in us and cause us to become quite. We develop more harmful behaviors. How many of you can't wait for your loved one to go to sleep so you can have drink it? And how many of you are getting out there to do your exercise? I do that. Good. All right. Good. But again, so those are some of the harmful behaviors that we're talking about. Obviously, the drinking is typically the number one, but a lot of times it is, sedentary lifestyle. You're not eating well. You're you're on the go all the time, it's rushed, you're eating fast food, processed foods, whatever. So there's just more harmful behaviors that tend to crop up when we're in the caregiver role. And because of that, we wind up having worse health, right? Because we're also putting things off for ourselves, right? We're not getting out there making sure we get our mammogram and going for our blood work and doing all the things that we know we need to do for ourselves, putting all of that aside. We actually had a member here at Town Square whose wife was his primary caregiver, and she just kept putting everything off. And one morning he didn't show up at Town Square, and he called and called and called, and we finally called the sheriff and said, you need to go over and do a wellness check, and they found both of them on the floor. That was about 4 weeks ago. She's still in the hospital, and he's been placed in a memory care unit because there's nobody to take care of him. But her health was a disaster because she was so focused on taking care of him that she wasn't taking care of herself. And so many times you can get into the weeds and not even realize, oh my God, it's a year and I have to have my teeth cleaned. Like, they think, oh, I'll do that later. And you just keep putting these things off, and ultimately it impacts your own health. And so that's where the increased risk of heart disease and, just lower levels of self-care. There's only so many hours in a day, right? And I spoke to a husband yesterday who said, I spend my whole day, by the time I get the laundry done, because she's incontinent every night, right? And I get the bed changed, and I get her clothes done, and I'm back here at Town Square picking her up. My whole day is revolving around caregiving. So, it's very common that we see that in terms of why we're not surviving the caregiving role. So ultimately, caregivers do pay the ultimate price for providing care, and that's increased mortality. That elderly spousal caregivers at age 66 to 96 who experience caregiving-related stress have 63% higher mortality rate than the non-caregiver. Because a lot of your loved ones who are in that moderate stage of dementia are sort of living in their own little world. They're not stressed. They're anxious because they don't understand what's going on, right? But they've got their touchstone. As soon as they see you, right, their anxiety goes down, right? They know you've got everything under control, right? Right? And so they're living in their nice little world that's not stressful for them, but is incredibly stressful for you. Myself on track here. Okay. Signs of caregiver stress. Feeling overwhelmed or constantly worried. Feeling tired often. Getting too much sleep or not enough sleep. Gaining or losing weight. Again, I don't have time to eat, or I do have time to eat, but I'm going to grab a burger because it's quick and fast and my weight starts to go up. Becoming easily irritated or angry, number one sign of depression in elderly. Irritation and anger. Looks very different than younger people who have signs of depression as more apathy, like they don't enjoy anything anymore, they don't want to do anything. In older folks over 65, one of the number one signs of depression is irritability and anger. Just no tolerance for anything. Losing interest in activities you used to enjoy. So anhedonia is what we call that. You used to love to go to the theater with your friends. Now you can barely get yourself off the couch at night after you're done with your caregiving role, right? Feeling sad. Having frequent headaches, body pains, or other physical problems. Using alcohol or drugs, including prescription medications, right? Seeking out self-medicating, whether it's with food or with alcohol or with prescription medications to make yourself feel less anxious, feel less depressed, right? All right, so let's talk about strategies to prevent caregiver burnout. I think the first one is the one that I have the hardest time with families with, and that's accepting help. And there's a lot of reasons why it's hard to accept help. You don't want to burden other people, right? Sometimes help is expensive, talking about bringing outside agencies into your home. You don't even really know what what do I need help with? Like, what could you possibly do to make my situation better, right? And I think that's really where we have to be able to look at and kind of chunk things out and break things apart. That it feels so overwhelming when we look at the whole situation. We need to look at small pieces of it that may be helpful for us. If you have a neighbor who offers to pick stuff up at Publix for you every time she goes, let her. If you have a neighbor who wants to come take your loved one out for a walk in the neighborhood, let them. When people offer to help, you need to figure out a small way. If you have enough of those little small chunks, they add up and it becomes particularly helpful. Focus on what you're able to provide. And so you need to really look at what's realistic. And I find that this is in mental health kind of globally, one of our major issues is unrealistic expectations. When you expect more than you're able to do, and then you're unable to do it, you feel like you're a failure, you feel like you didn't accomplish it, you feel like, you could have done better, and it affects your self-esteem and your self-worth. When we try to do too much with our loved one who has dementia, we set ourselves up for failure. So you have to be reasonable about what your expectations are. Does that make sense? So that leads into the next one. Set realistic goals. And I tell people, make lists. Make lists of all the things you want to do. And then pick 2 or 3 things on that list for that day. And it's not clean out the garage. Because that's not a realistic expectation for one day. It's get to the bank to get the documents I need for my tax attorney. Call the dentist and make an appointment. Then you make your little list with your little boxes, and at the end of the day, you got 2 checked off boxes, and you say, I did it. I completed the tasks I set for today. If you make them too difficult, you're not going to reach them. Get connected. I mean, there are, and we'll talk about this in a minute too, in terms of town square. There are support groups. There are church groups. There are, families that are living with people with dementia. We get the YMCA does their support groups. We have the Friendship Center down in Sarasota. There are avenues and ways for you to get connected to people who are in the same situation you are. I don't have a Facebook. I'm not a big Facebook person, but I do know that there are some Facebook groups that you can get some connection with, and some people who are living with the same situation. You just have to be careful about some of the information that's sort of disseminated through them, because there are lots of links. So you just have to remember, people need to share their experiences, not necessarily, medical information from them. Join a support group. I mean, we have, I think now 6 support groups going a month at Town Square. Between the early onset, our regular support group, we have a Parkinson's support group, we have a mild cognitive impairment support group. So we try to meet everybody's needs, and you can come to all of them, even if you're not in that particular setting, because you can glean and learn information. Other people are going through the same things that you're going through. Seek out that social support. Call people. Make a plan. Every day you're going to pick up the phone, you're going to call somebody. Your best friend, your niece, your daughter, your son, and you're going to have some social interaction with that person for 5 minutes about nothing about your loved one who has dementia. We need that social support. We need that social connection in order to keep our cup filled up, right? And it's really important. Set personal health goals. Like I said, if that one goal on the day is to call the dentist, call the primary care, call the cardiologist, make your appointments and keep them. If that means your neighbor says, I'll come over and sit with your loved one so you can go to the doctor, accept their help. Rest is really hard. Rest is a hard one, right? Because if you have a loved one who's up all night long, it's very difficult to get rest. But that's where you have to reach out to your healthcare provider. If you go to your primary care and they go, then you got to find another healthcare provider, right? You got to find somebody who's going to help you deal with the behavior of the situation that your loved one is having, so that you can maintain your health. Because just saying, well, they've got dementia and they don't sleep, that's not good enough. There are answers out there, and you have to seek them out. And see your healthcare provider. Do not let your health slip while you are being a caregiver for your loved one with dementia. It is way too important. Most likely, if you maintain your health, the person with dementia is going to pass away before you. There is a light at the end of the caregiving role. Okay? Create a safe and trusted social network to expand resources for caregiving and respite. This is where these groups are great for meeting people, finding people who are in the same situation you are, so that you can, outside of town square, begin to meet with each other and support each other and understand what dementia looks like, right? Because it's very difficult. We all know this. As a matter of fact, Skylar is now making up her business card with her name and information on it. On the flip side, it says, I'm living with somebody with dementia. Your patience is appreciated. So that you can hand that card out when you're at the restaurant and your loved one's like, well, why didn't you get his food first? I ordered before he did, and the whole restaurant hears what's going on, right? And everybody's looking at you and you want to crawl under the table, right? That's when you slip that card to the waitress and she diffuses the situation for you, right? Engaging in creative activities with your loved one. This is a really important one for me because I find a lot of times, you know, outside of town square, when people are home with their loved one, I say, well, what do you do all day? Well, I've got work to do, and I've got to do laundry, and I got to cook, and I got to clean, and what's your loved one doing? Well, they're sitting in front of the television. You know what? Nobody's going to know when you're dead that your toilet is clean or dirty. You know, there are just things that we have to let go that we can't possibly do every day. And so spending time with your loved one who has limited time left with you during a time of day when they're probably at their best, between 10 and 12, right? And getting that personal time with them, that one-on-one, that eye contact, is going to be good for you and your soul, and it's going to be good for them. But there's only 24 hours in a day. So there may be things that you have to just put aside and say, not important this year that I put up every Christmas decoration that I've ever owned before. A little tree like this, I'm good, right? We talked about this at realistic goals for the day. Do not ignore your feelings or your emotions. Please. If you are crying yourself to sleep every night, if you don't want to leave your house anymore, if you just feel overwhelmed and you just want to shut down, please reach out for help. We talked about what the small things slide. And the last one I put on there this morning, actually, when I was thinking about this, was grieve. Grieve the loss of the loved one that you no longer have. Grieve the spouse that you no longer have. Grieve the aunt that you no longer have. Grieve the grandmother that you no longer have. Their body's here. And every once in a while, you may see that glimpse of them come through when you're sitting there actually attentive and playing a card game or talking about it, going through a picture book of when you were a child. And you may see a glimmer. They may show up again. But those are the times that you have to cherish, because those are the times that are limited in what's coming now. And so you have to acknowledge for yourself that you're grieving that loss. And once you can accept that a little bit better and understand where your feelings are coming from, it tends to help the irritability and anger sort of abate. All right, resources. So pretty much all of you know about Town Square. We talked about that before. But again, Town Square is a variety of resources. It is not just the day center, right? It's Skylar talking about the retreat. It's, you know, do you need an elder care attorney? Do you need an RN care manager to help you? Is there, you know, what is it that you're struggling with that we can help you find resources and supports for? The support groups, like I said, some really great support groups in the community as well as here. The educational series, I mean, I think the more you guys learn about the disease and all of the things that are going on, I struggle sometimes to figure out new topics, which is one of the things I'm going to ask you all today at the end of this. What else do you want to hear about? I feel like sometimes I do the same ones over and over again, and sometimes you need to hear them a couple of times, and sometimes I try to mix them in, like by going through the dimensions again at the end of this talk, right? Church groups. This has become a really, especially down in this area, I've really started to notice some really great advertisements right out in front of the church groups that they're offering support groups, or the gentleman just came in whose wife passed of dementia, and he had done a 12-week grieving support group and found it very helpful to kind of move past what had gone on for him. So don't forget that, and you don't have to be members of a lot of these churches. You know, it's Baptist, it's Methodist, doesn't matter. It's open to all denominations to use their resources. So don't forget about those. Okay? I think I did good. 40 minutes. Questions and answers. All right. Anybody have anything they want to share? Anything they want to ask?
One of the biggest struggles I have is this whole idea of who is the large government outside of China.
Yep.
I feel like it's not
Right.
and this is very stressful because he's still different.
Correct.
Yeah. That's what
So what she's talking about, and we hear this a lot, especially with women caregivers, that they feel like they're now in the role of a mother. And there's a term called anagnosia, which I've used with many of you before. It's where the person with dementia doesn't have the cognitive ability to know that there's anything wrong with them. So wrap your brain around that, right? I am cognitively impaired, but I don't have enough cognitive ability to recognize that I'm cognitively impaired. So I'm going to tell all of you there's nothing wrong with me. Not because I'm in denial, not because I'm stubborn, but because I really don't see that there's anything wrong with me. I mean, I literally have people sitting in a wheelchair with no ability barely to walk, and they'll tell me, well, I can drive. Why do you think I can't drive? Because you're sitting in a wheelchair? Like, but they can't see it. They can't see it. Or they downplay it. Right. Right. But it's not that bad. Correct. Right. Right. So the child, but they're still treating you like their wife. And they still expect to be treated like the husband. They still expect to have yeah. So there's the husband kissy stuff too. There's that. But there's also I want to make the decisions with you, right? Like you're going to sign over the change over the will or whatever. And I need to understand all of this, right? It's anagnosia. Yeah, I'll spell it for you, but not right now. The reality of it is that we give too much information to people with dementia. Less is better. And they can't understand it. So now you've given them a piece of information that cognitively they don't have the ability to understand. So you want to simplify things for them. You also don't want to give them too much anticipatory information, like we're going to travel in 2 weeks, because then every day you're going to wake up and say, "When are we going? Why haven't we left yet? We're leaving tomorrow, right?" It's because this is your spouse. That's the grieving I'm talking about, right? That's the part that's so hard. And now, and I like to see it as being a good steward of your husband's emotions. You're not going to give him information that he can't process and use because it's anxiety producing for him, and then he becomes difficult for you to manage. And that changes from day to day. That's the other thing. And then you realize, no, we're doing here now. Okay. You know, I say to people all the time, when was the last time you sat down with your husband and said, "Hey, do you know what day of the week it is?" I know, right? But when I evaluate families, sometimes a mother or whatever, and I come back and I sit down with the wife or the husband and I say, "Do you realize that your wife doesn't know where she is? She doesn't know that she's in this state. She doesn't know what day it is. She doesn't know." They're shocked. But think about it. I didn't send to John Haney, know what day it is. You know, I mean, it's just not something that we normally just assume that they know that information, right? And it isn't until we get into the farther states, right, where they ask us the same question a million times and we realize they don't know that information. But in that early stage 4, late stage 4, beginning stage 5, they can pull that off pretty good. And so it appear to other people to be quite cognitively intact, and we know what we're going through at home, right?
Restaurant or
They use a lot of what we call deflection, right? Say, oh, you don't want to talk about that because they don't know the answer to the question. They laugh about it. Yep. Yep. Yeah, they deflect really well. Yep. Yep. Or if they're smart enough and they can still do it, they'll turn the conversation around and ask the other person another question so that they wind up doing the talking, right? There's a clock actually that I have a lot of families buy that actually has all of that information on it. That the patient I went to see this afternoon, the wife was telling me, oh yeah, he loves that clock. He's got it right up on the windowsill, and he can look up and it says, you know, Wednesday, April 16th, and the time, and a big AM and PM, so he knows, and he glances at it all the time. Yep.
Now, I had written on it beginning of, I don't know, maybe even last year, Mark in Florida.
Well, and that's the other problem too, is that sometimes they're auditory processors, sometimes they're visual processors, right? So if they're a visual processor, then they can still read that and understand it. But if they're an auditory processor, they need that Siri saying, it's April 16th, Tuesday, you know? Right. Right. Then you also have to realize that some of this information is just superfluous. It's not important. If he thinks he's in Michigan, who cares? Who cares? Yeah, we're in Dayton. Isn't that great? We're in Dayton. It's not dangerous. It's not going to hurt him.
He said, whenever, he said, well, I want to go to Florida. I said, okay, when do you want to go? He says, well, let's go tomorrow. Okay. And an hour later, I said, wow, it's great to be back in Florida. I'm glad we got here. Because we haven't lived here. That's our conversation. And in a walk, in one walk. Yeah.
Right. Yeah. No, we call those therapeutic untruths, right? We don't call them lying. We're not lying. We're using a therapeutic untruth because we don't want to tell that person that they're wrong. Nobody likes to be told that they're wrong. Nobody. And if he believes that he's in Dayton to the core of himself, so what? And you're just going to upset him if you tell him that he's not. So now there's times when we do have to reorient, right? When, oh, I'm going to get the keys and run to Publix. Really? Because you haven't driven in 2 years, right? So that's not going to happen. Then you say, oh, you know, the battery's dead. Or, gee, we have a flat, I got to get that fixed. Or the tires are low. It's something, right? You try not to, but then if they really dig their heels in, then it's like, you know, no, you can't drive. You have to then, at that point, for safety reasons, but that's the only time we encourage families to reorient their loved one. The rest of the time, it's redirection. If they want to think they're in Texas, they're in Texas, right? That's fine. Not hurting anybody. But that's a hard one to learn, too. It's just natural. If we're natural, and especially women and men who are, you know, natural teachers and taught our children, right? Somebody says something, that's just our natural reaction to want to, we're not correcting them to be mean, we want to teach them. This brain doesn't learn.
My husband, after 8 years, moved to where he was, Dayton or Florida. So about a year ago, when he started coming here, he didn't know where he was. And across our lake is another home. And about a year ago, he started saying, oh, that's my home.
Mm-hmm. There's my friend's house that's across the street. And I just started saying, yes. And then one day, like cleaning
months later, he says, I see my house over there, like, nobody's there. I know that's my story. I don't know what light bulb went, and he said, I see Billy's over here, but I know that's not true. And I said, you're right.
Yeah.
So we said,
Yeah. And I find too that when a lot of times when they say I want to go home, it's really not a place. Because if you ask them, well, where is home? They don't really know where home is. Home is where you feel comfortable, right? Home is when you walk into your current living situation and it smells familiar and you see familiar things and your stuff is there and you're like, ah, I'm home, right? You ever come home from a vacation and you just can't wait to get into your own home with your own stuff, right? That's what they're looking for. They're looking for that feeling that gives them that sense of home. And so that's oftentimes for me an indicator of when that anxiety level is way up there and we need to do something about that because
It's supposed to say, I mean, this was not every day.
she says, I want to go home.
Yeah, it's just down the street, or it's just, I live with my mom down the street, who lived down 12.5 years ago.
Or you want to try to engage the conversation without potentiating the conversation, right? So you want to say, oh, is your mom home now? And then see what she comes up with. And then you want to try to steer her away from, it's the afternoon. I think your mom's working. We'll go down in a little while. And then you move the conversation away from that and you try to come up with something that engages her and get her back into that engagement, whether it's music, whether it's usually not television. They're not good with being able to watch TV. But sometimes you can get out those dish towels and ask her to fold them again for the 15th time, right? She just folded them, you go in the bathroom, in the bedroom, and you dump them all out again, you bring them back out again, and you give her something to do that makes her feel like she's contributing, like she's doing something. Honey, I'm so busy, I could really use your help. Can you fold these for me first, and then we'll go down and see your mom. Now, if it's constant, back and forth, then she needs to be evaluated and make sure that she is on the correct medications to bring that temperature down a little bit. Yeah. Right.
Where's that?
She's telling you she's not feeling comfortable in her own skin.
Give me an address and I'll take you there.
Right. A lot of times they don't know that you're your husband, they know that you're somebody familiar. There's somebody you love, you smell, you sound, they recognize that. They're not really sure who you are. Yeah. Right.
that's not a helpless situation. I always wants to go home. I sometimes think like, well, I'm sad. I don't know.
Well, they're not nice. They're truths, right? I tell people, like, you don't tell children, don't talk to strangers because there's rapists and murderers out there, right? Because that would be distressing to them. You're not going to tell your husband that his mommy is dead. That's distressing to him, right? So you're going to come up with a story.
That's why I make it a game with my husband in my mind. I'm playing a game with him. How? And even my grandson does this. He says, Grandpa will ask me the same questions, and he says, I embellish the story every time he asks me and make it funnier. So he says, I love that because I get to tell over again, and I find great ways to make it funny to him. And I was like, wow, that's a great idea. That's my 21-year-old grandson. So stop asking. And if you can make the most ridiculous things funny, you cannot believe what you can make funny. You got to find it funny. Maybe that's just my husband, but
I agree.
but it works for us.
Do you have a question?
What I was going to say is, when you're asking for suggestions,
Yes, for other courses. Yeah.
maybe it would be a type of way to use this is for you to sort of have a session where you rehearse
Okay.
You know, maybe you could.
So you could do some like role play a little bit.
Around
behaviors. That's a good idea. Thank you. Yep.
I could imagine.
I appreciate it. Thank you.